Hello, I'm Eddy Barasch from San Francisco Hospital, and this is the last segment of our presentation, The Many Faces of Aortic Stenosis, in which I would like to share with you a few potential reasons for discordance between transvalvular gradients in the aortic valve area, the current recommendation for aortic valve replacement, and some home-taking messages. So causes for low gradients in the presence of aortic valve area less than 1 centimeter square in patients with preserved left ventricular ejection fraction comprise, first of all, errors in measurements due to incorrect positioning of pulse wave Doppler sample volume in the left ventricular outflow tract, incorrect alignment of continuous wave Doppler beam with the flow direction, and more frequently skipping one or more of the 4 required windows for the evaluation of aortic stenosis. In one study, more than 60% of patients had the highest velocity across the aortic valve out of the apical windows, meaning right parasternal and suprasternal views. Then there are inherent problems with assuming a circular geometry of the 11th coalflux tract, which actually is an ellipsoid, and on two-dimensional echocardiography, we are measuring its minor axis. This is an example of a patient who was diagnosed with severe aortic stenosis based on a LVOT diameter of 2.4 centimeter, correctly measured at the point of implantation of right and non-coronary cusp. And the same patient, the CT measurement of LVOT area gave an aortic valve area in the moderate range of 1.1 centimeter square. CT evaluation of LVOT area in another patient exemplifies here the ellipsoid geometry, which is seen also in a three-dimensional echocardiography with a minor and major axis of the ellipsoid. Other causes is that the aortic stenosis may be really not true severe aortic stenosis, but pseudo-severe stenosis. And we have a few tools which we are utilizing in our daily work in differentiation between true and pseudo severe stenosis, like projected aortic valve area, the valvular calcium load, which in women greater than 1200 Agatston units, and in men equal or more than 2000 Agatston units, stands for severe stenosis, and the role of flow rate when we evaluate these valves. A number of conditions like atrial fibrillation and severe tricuspid regurgitation, mitral regurgitation, or mitral stenosis may increase the prevalence of discrepancy between gradients and the aortic valve area, and explained by decrease in forward left ventricular stroke volume. As well, a right ventricular systolic function by decreasing the left ventricular preload leads to the same consequences, and lately constrictive pericarditis was added to the list of conditions associated with discrepancy between gradients and valve area. Inconsistencies in gradients we discussed in the first lecture, in which, if you remember, actually 1 centimeter square the valve area corresponds to 27 millimeter mercury mean gradient and not to 40. Small body size was cited also as a cause for this discrepant values between gradients and valve area. Now, low-dose dobutamine echocardiography, in other words, up to 20 micrograms per kilogram and per minute, has been proposed many years ago by Chris De Filippi and Paul Graeber as a tool to differentiate between a true or fixed, as they call it, stenosis and pseudo-stenosis, or what is called relative. So in fixed aortic stenosis, at peak administration of peak dose of dobutamine, the transvalvular gradient will increase, whereas the aortic valve area is unchanged or very little change, less than 0.2 centimeters square. These patients enjoy an increase in left ventricular ejection fraction after aortic valve replacement. On pseudostenosis or relative stenosis, the transvalvular gradient won't change very much. However, the valve area will increase, and these patients will have neutral response to ejection fraction. And the third category, or indeterminate response, where there is neutral response to a neutral result of transvalvular gradients and aortic valve area to dobutamine administration, and there is no increase in left ventricular ejection fraction after the aortic valve replacement. This cartoon illustrates the same thing. So in true severe aortic stenosis with normalization of flow, aortic valve area remain under 1 centimeter square, whereas the gradients will increase above the 40 millimeter mercury. Whereas in pseudo-severe aortic stenosis, with normalization of flow, we be an increase in aortic valve area, in this example, more than 1 centimeter square, and the presence of a similar low gradients under 40 millimeter mercury. So administration of dobutamine will elicit, will unmask the or determine the presence or absence of inotropic reserve or contractile reserve, as is called in this slide. So a normal response is expected to increase in stroke volume by at least 20%. So patients who have contractile reserve and have true aortic stenosis will show an increase in mean gradient in the setting of a fixed in the setting of valve area which unchanged from the resting condition, and they will benefit of aortic valve replacement. In pseudo-severe aortic stenosis, the valve area will increase with dobutamine administration. The mean gradient will not change very much, and these patients are considered deemed for medical therapy. The absence of contractile reserve will lead to indeterminate severity of aortic stenosis, as this patient has a higher operative risk. Today, it's recommended this patient should undergo the multidetector CT for evaluation of the valvular calcium burden and the threshold I mentioned in the prior slide for severe AS. There is evidence, new evidence actually, showing that these patients without contractile reserve will do better with TAVI than with surgical aortic valve replacement. Now, during dobutamine administration, there is an individual response to dobutamine in respect to the inotropic function, actually, to contractility. So the projected aortic valve area concept is that we should look at the change in the valve area, considering a normal flow rate of 250 milliliter per second, and an aortic valve projected equal or less than 1 centimeter square stands for true severe aortic stenosis, as an indexed aortic valve projected less than 0.5 to 55 centimeters square per meter square by the surface area stands for true severe aortic stenosis. More and more this calculated the projected aortic valve area enters in clinical practice because it has a greater value than the non-projected one. So just to give an example which will show its great predictive value, in this recent study, the hazard ratio for mortality in patients under medical treatment shows that the hazard ratio of indexed and unindexed projected aortic valve area are much higher than that of aortic valve area than less than 1 centimeter square. The gradients, mean gradient didn't come out even significant from this standpoint. So keep in your mind, please, that projected aortic valve area, it's worthwhile to measure, even that takes a little bit more time, and has a great prognostic value. Now, on other ways to look at the aortic stenosis is looking at indices unrelated to flow, in other words, flow independent indices, and this is valve weight. In almost 900 patients with severe aortic stenosis, this is a distribution of the weight. This is the number of patients. And we see here that the mean aortic valve weight for severe aortic stenosis, it's a little bit more than 2.6 grams. We looked also at the aortic valve weight in a number of patients who underwent surgical aortic valve replacement. And we looked specifically at the four hemodynamic groups, and we found that patients with normal flow low gradient, if you remember, who are quite similar with moderate aortic stenosis, indeed have a much lower, a significant lower valve weight than those patients who have classic severe aortic stenosis, normal flow, high gradient. And this is an unadjusted and adjusted for body surface area and annulus area. However, for clinical decision, the aortic valve weight doesn't help us very much. But fortunately, the multi-detector CT or EBCT, this is an older paper, show a nice correlation, strong correlation between aortic valve area and CT calcium of Augustin's score. So they are not superimposable, but they are very close correlated. So the calcium score by CT entered in a clinical armamentarium for the aortic valve severity evaluation, and is able to give us precious information in patients who have discordant indices of aortic stenosis, but still clinically they look like severe aortic stenosis. Now, the distribution of calcium is it's gender related. Women have a lower calcium burden for the same severity of aortic stenosis due to predominant fibrotic changes in the aortic valve, and compared with patients with moderate aortic stenosis, A are the males, here are the females. Patients who have classic aortic stenosis, in other words, high flow, normal flow, high gradients, have a higher calcium score, close to 5,000 in males and close to 3,000 in females. And this showing us how the concordance between the gradient in valve area and the aortic valve calcium is playing an important role, especially patients who have classic aortic stenosis. Those who have paradoxical low flow, low gradient aortic stenosis, the calcium score it's less, but its value is still present when one wants to validate the impression of severity as it results from the echo Doppler evaluation. One last point, it's the importance of blood pressure during evaluation of aortic stenosis severity. We have to make sure that the blood pressure is within normal ranges, because the higher blood pressure will dampen the gradients and underestimate severity of stenosis. And if we look only at the gradients, this is an example from animal lab with aortic bending, and as we increase this is the left ventricle pressure curve. This is the aortic pressure curve. You observe here as we increase the aortic pressure. Here it's 100. Here it's toward 120. Here it's 100 and almost 180. And the presence of similar valve area 0.5, 0.5. The gradients, they almost halved from 43 to 22 when the blood pressure was increased. So this is a demonstration in the animal lab of the importance of systemic systolic blood pressure for the evaluation of transvalvular gradients in severe aortic stenosis. Now, how one can explain the low pressure gradients? In our view, aortic stenosis, in addition to high systemic vascular resistance and low arterial compliance, which has been shown in patients with aortic stenosis, especially in the elderly, increases global afterload of valvular arterial impedance. The increase in global afterloads, in other words, a double load to left ventricle ejection resulting from the aortic valvular stenosis and increase in systemic vascular resistance will trigger left ventricular will trigger the development of left ventricular hypertrophy. And on one hand, and the other one will change the myocardial matrix, so increasing the collagen deposition and appearance of myocardial fibrosis. Left ventricular hypertrophy will lower the size of the left ventricle cavity, decreasing the stroke volume, but also had deleterious effect of on the myocardial function as of myocardial fibrosis, and both of them concur to subclinical left ventricular systolic dysfunction. Measured here by or expressed here by decline in systolic indices. This is the mid-wall fractional shortening corrected for end systolic stress and global longitudinal strain. So decrease in contractility will decrease the pressure in the end, will decrease the pressure gradients. So in general, we should look at the aortic stenosis not only at a disease of the valve itself, but of the ventricle and the implication of the aortic properties and the peripheral vasculature to contribute to increase the resistance to ejection of blood in systole. So the ventricle is exposed to two loading condition. One is it's at the level of the valve, and the other one at the level of the aorta and the vasculature. And this increase in aortic impedance, decrease in aortic compliance, increase in capillary resistance, because especially the group of patients with aortic stenosis treated today are the adults, the elderly, who have comorbidities, and atherosclerosis contributes to changes in the properties of the vascular tree. So what are the current recommendation for aortic valve replacement? First of all, we looked at, as Catherine Otto wrote many years ago in an editorial, listen to the patient and look at the valve. So there is an abnormal, if there is an abnormal valve, aortic valve with reduced systolic opening, first thing, if we have to see if the patients are symptomatic, and the symptoms indeed are due to aortic stenosis or they are asymptomatic. In symptomatic patients with severe aortic stenosis and concordant results, concordant values of transvalvular gradients of velocity, which is here more than 4 meters per second, and or mean gradient less more than 40 millimeter per mercury will be the stage D1. Remember, please, as D stands for patients who are symptomatic. And these patients should go to aortic valve replacement. It's class 1 recommendation. However, some patients with symptomatic aortic stenosis may have discordant results, discordant values between the velocity and the aortic valve area. So you can see here that the peak velocity is less than 4 meters, but the aortic valve area is still the 1 centimeter square. So next step will be to look at the ejection fraction. If the ejection fraction is less than 50%, they have severe aortic stenosis, stage D2, and dobutamine stress echocardiography, if we will elicit at Vmax velocity, maximal more than 4 meters per second at any flow rate, it's enough to send this patient to aortic valve replacement class 1 recommendation. If they do not have, if they have a normal left ventricular ejection fraction, this will be severe aortic stenosis stage D3. This is paradoxical low flow, low gradient normal EF stenosis with a valve, adjusted valve area less than 0.6 centimeters square per meter square and stroke volume index less than 35 milliliter per meter square. If these symptoms are really related to aortic stenosis, this is a class 1 indication for aortic valve replacement. Remember, please, here the value sometimes of the calcium score, projected aortic valve area also. In the prior recommendations, the prior edition of the guidelines, the stage D3, so paradoxical low flow, low gradient, got only a 2A recommendation, but was elevated to the level of class 1 recommendation. Now, in asymptomatic patients who are more difficult to manage, if stage B, meaning progressive disease, this is moderate aortic stenosis, if the patient has also needs to undergo other cardiac surgery, surgical aortic valve replacement is indicated the level of recommendation 2B. And if the patient is asymptomatic but has severe aortic stenosis, here you see it's only based on the Vmax or velocity maximal equal to more than 4 meters per second. Then we look at the left ventricular ejection fraction. If LVEF is less than 50%, they will go to aortic valve replacement, surgical or TAVI, class 1 recommendation. Class 1 recommendation is also if the patient is in stage C, in other words, asymptomatic but severe AS, and undergoes other cardiac surgery, class 1 recommendation. However, these patients without symptoms, they will, most of them will may undergo an exercise treadmill test, and if the results show a drop in blood pressure or the reduced exercise capacity, a surgical aortic valve replacement is indicated, receiving a 2A recommendation. In patients who have very high velocities, a very high gradient, more than 5 meters per second, or brain natriuretic peptides threefold in normal, or rapid disease progression, and they are a low surgical risk, surgical aortic valve replacement is recommended as a 2A class. And finally, in the patients who are asymptomatic with severe aortic stenosis and the left ventricular ejection fraction start to drop less than 60% on 3 serial studies, surgical aortic valve replacement is recommended. Now, looking at low flow, low gradient, low EF, classic low EF aortic stenosis. how we decide what to do with these patients based on dobutamine stress echocardiogram. If there is inotropic reserve, stroke volume increases at least 20%, and the patient has a concordant results between concordant values of mean gradient with the aortic valve, in other words, high gradients and low effective orifice area. This is true severe aortic stenosis. A heart team risk assessment is warranted. If they are intermediate or high or extreme high risk for surgery, TAVI is indicated. If they have low risk for surgical aortic valve replacement, TAVI or surgical aortic pending low risk trial results, and favor TAVI if not inferior. And we know now that patients who at low risk have been enrolled in studies, and they have good results with TAVI not being inferior. Now, another response to dobutamine stress, if there is inotropic result, reserve, but the mean gradient remains less than 40 millimeter mercury, and the aortic valve area increases more than 1. You remember that this is pseudo-severe aortic stenosis. So these patients, in these patients, is recommend medical therapy versus considering enrollment in TAVI unload trial, which is still enrolling patients, and the results we'll know probably next year. Patients without contractile reserve favor TAVI if aortic stenosis is deemed severe, based on multi-detector computerized tomography with a calcium score in women equal or more than 1,200 angstrom units, and in men equal or more than 2,000 angstrom units. So class 1 recommendation for TAVI, simplifying these two slides. When are recommended, the last recommendation for TAVI in patients older than 80 years old or younger with a life expectancy less than 10 years, or in patients of any age with high risk surgery, who have high risk surgery and life expectancy more than 1 year. In these patients, TAVI is recommended more than a surgical aortic valve replacement. Surgical valve replacement is indicated today for symptomatic or asymptomatic younger patients less than 65 years old with a life expectancy greater than 20 years, or in asymptomatic patients with abnormal exercise treadmill test, very high, at least threefold increase in brain natriuretic peptide serum level, or very severe, meaning AS, meaning peak velocity in excess of 5 meters per second. These patients are recommended to undergo surgical and not transarterial valve implantation. And TAVI or SAVR, or surgical aortic valve replacement, is recommended and depends on the heart team decision in symptomatic patients between 65 and 80 years old, or in asymptomatic patients less than 80 years old with ejection fraction less than 50%. So TAVI or surgical aortic valve replacement, symptomatic patients between 65 and 80, or asymptomatic less than 80, but with lower ejection fraction. So a few take-home messages. Severe aortic stenosis with preserved left ejection fraction and low pressure gradient is a diagnosis of exclusion with heterogeneous patients, and pseudostenosis should be ruled out in a significant number of them, preferably employing the projected aortic valve area method. Correct measurement of LVOT diameter and TVI is critical. Prefer 3D echo for LVOT area. Stroke volume index and dimensional index have prognostic value and should be measured and reported next to valvular arterial impedance, whereas the flow rate is useful in validating the prognostic value of aortic valve area. Lack of inotropic result, but the bitumen stress echo prompts aortic valve calcium score measurements, and TAVI is preferred to surgical aortic valve replacement. The pressure gradients have a great specificity with prognostic values, whereas aortic valve area is a sensitive variable. Although normal flow low gradient seems to have a more benign prognosis similar to moderate AS, up to 50% of these patients may have severe stenosis, and it's possible to be an intermediate stage between moderate and severe aortic stenosis, close follow-up being warranted. And finally, be aware of low flow aortic stenosis. Thank you very much.